And there's a ton of slides, I apologize. I guess inherited this lecture a little bit, but we'll go over all the important stuff and kind of talk about that. So you have a lot of reading to do. And it's good for hitting the high points, so it's good to know and a reference, because sometimes you'll get a bunch of slides that have like 10 slides and the guy talks for an hour, or 10 slides, you're like, whoa, what's he talking about? So this is very, very complete. So we'll talk about some things and focus on the high points. Pelvic pain. Basically, they used to say anything for the belly button down, but as belly buttons change and the patients have changed, I've been saying, anything. I've had ovarian torsions that have hurt, right upper quadrant and things like that. So abdominal pain. And pelvic is typically lower, but it's not always location like that. So, ovarian cysts, ovarian torsion, vaginal bleeding OB patient, placental abruption, previa, ectopics, miscarriage, mastitis, preeclampsia, eclampsia, and sexual assault stuff. Okay, so the objective is to try to learn as much as we can in the next part here. All right, so we'll focus on mainly non-pregnant female, because that's a whole other world of problems. But and on this side, it says abdominal pelvic pain is the single most common reason the ED visits, constitutes 6.8% of all visits. I don't think I got this number. It's 40%. Abdominal pain is 40% of visits to the ER. Like, my tummy hurts, I'm here for 40% of the time. The benign etiologies need to be sorted out from potentially life-threatening conditions, differential diagnosis of pelvic pain. Yeah, there's a million things that can go wrong. There will be a problem, or there could be absolutely nothing wrong. So probably a possibility. So history, you guys know how to imagine good history, and then there are certain things that do play. Like, so in the ER, some of the more important questions I want to know is, when did all this start, and did it get worse? Like, why are you here today? Like, these are some clear questions that you can get lost if you're not careful. So they'll say, oh, Don has gone for 2 months, and they're going to tell everyone different stories. So like when they get to you, they've talked to the person out front triaging, or the person answering the phone. They've talked to the nurse. They've talked to the registration people come and talk to them, and they've talked to everybody else. So just understand, like when they come talk to you, they're going to be tired of telling their story. They may paraphrase, so like you got to be like, why are you here today? Like, oh, I've been back pain for 6 months. Okay, 6 months. Why today? Why at 3 o'clock in the morning on a Friday night? Like what's going on? So things that worry me are sudden onset. Worsening all of a sudden. Like, so getting these, like, did it start all of a sudden? Has it been kind of going on? Then all of a sudden it got worse than it was before? I mean, something triggered people to come in. Was it family that finally annoyed you enough? I mean, did you get off of work and then come in? I mean, so that'll help you give such a bigger picture of the real story, what's going on here. Because people, and different kinds of patients do different things. Some guys are dumb, they'll stay at home for way longer, and then they're like, oh, I feel a little better now that my appendix is ruptured. Maybe it's a little bit better. And then they get a little more sick, and then they wonder what's going on. So all those things is important. So, and you want to obtain detailed gynecological, obstetric, history of all these different things. So, you want to know what abdominal surgeries they've had, complications, and LMP is helpful, but it's not very accurate at all. And as you guys know, always ask if sexually active, possible exposure to STDs, and you guys rotate your clinic here? No, you don't, do you? Okay, fine. Yeah, student clinic on a campus is always interesting because it's STDs and dry scans mostly. But anyway, so birth control, what kind, if they take it, and that kind of stuff. So, all right. So, labs and imaging, pregnancy test. Like I said, anyone who's got the plumbing gets the test. Period. Don't care if they've had a tubal. I can tell you, on more than this many occasions, I've had to tell a lady that she has positive pregnancy test and she's had a tubal. So do not go, oh, you got a tubal? Oh, what for that? No, even more so, because of risk for ectopic pregnancy and stuff like that. So just be aware. It's an effective procedure, don't get me wrong, but it doesn't mean that you can't get pregnant. It'll probably keep you from having a child, because if you do get pregnant, it's most likely an ectopic, but still. wet prep, GC chlamydia, CBC, UA, those are most of it too. But don't forget, I mean, you want to get your basic labs to your BMP also, I would add on there. And also a lipase, have a low sensitivity for reporting lipase, because pancreatitis can refer pain down too. So those sorts of things. We have 100 labs, so let's try to get through something. So ultrasound is most important for looking at the pelvic anatomy. The CT or CT is very helpful with IV contrast. So on a side note, so do it a CT or not. This is always like a hard problem for people to understand. When do you use? So you're doing a CT scan of someone's abdomen and pelvis. There's two different kinds of contrast, right? There's oral and IV. And when do you use oral? When do you use IV? Did we talk about this last time? No, sure. Okay, so basically oral is going to be in the gut, right? And if you've got kidney problems, don't worry about it. It doesn't affect the kidney, so that's great. So if you've got some renal function problem with the patient, then you can give them oral. So if you have to worry about a hole in the kidney, there's a hole in the gut, you want it. So there's a big long list at my shop that always talk about like, oh, recommendations of oral versus IV only versus IV and oral. And with and without is pretty much out now. People don't really do with and without CTs anymore because it's double radiation. You can usually get it all with the contrast. So anyway, so basically if you've got a hole in your gut, you want contrast. So recent surgery, perforation, like a bleed, those sorts of things you want oral contrast. Because if you're worried about something inside the gut getting out into the pelvis, you want oral, okay? IV though, most of the time, other than that, IV is all you need, the rest of it. Because IV sees everything else, and you don't have to wait an hour to get a scan. That's the other thing, like time is of the essence on some of this. You don't sit around and wait an hour for oral to get down to the lower gut. So, that's super important. And then on top of that, I mean, you could do a CAT scan without contrast for for kidney stones, and that is the only time really the recommendations are without contrast. But if you don't see the stone, you're kind of hosed because you don't see anything else either. So if you have appendicitis, you think it's a stone, it's not. You need to scan them again or send them home. So anyway, that's just kind of my side effect. So other than those things, then you want an ultrasound. So, but with women in particular, the ultrasound can see things better, but the CAT scan is pretty good at torsion though. It really is. So, and we'll talk about that. But I'll go off on that tangent. But all right. So pelvic pain. Yeah, I don't know how you got all this. Off of that. All right. So PID, pelvic inflammatory disease, acute community acquired STD or STI. Now they all call it now. It's actually transmitted illness. This is the most common cause of gynecological visits. And so, if anybody has lower pain and other discharge, some women will not want to tell you have the discharge. Oh, you have discharge? No? Okay. And then you go to do an exam anyways, and it's like, you can't see anything because it's just so much discharge, right? So this would be considered positive for discharge, you know, when you're having to use like suction or other things to try to just be able to find the cervix. So people resist it. And apparently there's a study that said like guys will never admit they have discharge. Like that's like really rare. So if a guy comes and says he's got discharge, like that's something seriously wrong there. But for women, for PID, basically it's mostly young women. They've had multiple, oftentimes sexual partners, no barrier protection, and most common is chlamydia and gonorrhea. So the other ones too you can get is the normal thing is like bacterial vaginosis is a common amount of bacterial overgrowth. It's a normal flora that will overgrow and cause a lot of discharge, and so that's when you have positive Kluzel's. I'm sorry, I'm trying to go through the high points without having to go through every little thing here. So, and you'll get that back soon. So there's two tests. The gonorrhea and chlamydia oftentimes are a clinical culture that'll grow, take a couple days to come back, so you're not gonna get those results. But based on what you see, you're gonna need to sometimes treat, just go ahead and say, we're gonna treat you for this in case you have it. But you'll get back trichomonas, you'll get back the wet prep for concerns of like bacterial vaginosis and stuff right there. So you have to make your determination if you want to treat them all at once or not. So PID is ascending infection from the lower to the upper tract. A lot of times I guess they occur right after menses. Signs and symptoms. Pain and discharge is most of it. The rest of it is going to be highly variable by the patient. And so as pain gets worse higher up, different women are different ways. I've had some with very minor bacterial vaginosis that have just terrible tender abdominal pain. I've had some that have had a huge tubulovarian abscess and they're just like, oh, it hurts a little bit right here. It's just like, you know, so your exam can be helpful, but imaging and doing the test can also be very helpful. Lower abdominal pain, common, worses during intercourse. It suggests a PID, but also a lot of other things get worse too, like endometriosis. Usually bilateral, presenting for more than 2 weeks. Because ovarian cysts are usually on one side or the other, not both. And that usually changes too, ovarian cysts, because every month you ovulate on the other side, back and forth. So new discharge, basically new pain. Fevers and chills are common, but usually later findings. So looking at PID, there's a lot of stuff you guys are going to be able to just read and know for your test. You do an exam, you look on the outside, you look for any kind of skin lesions or any kind of obvious trauma or other abnormalities. The cervix itself, you look at it and depending on if it's red and friable, and it can kind of indicate different things. That's where your cultures will come into play to help drive what you do. But almost every single time you're going to do the same thing. You're going to do a pelvic exam and you're going to look at the cervix and see if it's open, if it's closed, what kind of discharge there is. You're going to take your samples and you're going to take your GC chlamydia samples, your wet preps, and then go from there. So depending on what you see will dictate what you do, but most of the time you're going to send everything because it can look normal and still have positive chlamydia. Also, so the bimanual exam, so cervical motion tenderness, this is a test people underestimate, but I think it's very helpful for determining if it truly is what's causing their symptoms. If they have tenderness in their cervix, it can refer pain up into their pelvis. And so what you do is you do your exam and everything, you look at it, and then you test to see. You say, okay, I'm going to put some pressure on your cervix, and you say, tell me if this reproduces the symptom that you're having. You push on it gently, and they will usually just jump up off the bed and say, is this very, because it's an uncomfortable thing, and it hurts. But it isn't always going to reproduce all their symptoms, so keep that in mind. So it's, you know, you got a broken arm, you can hit it with a bat, it's going to hurt whether you're broken or not, right? So just keep that in mind, be careful. Minimum criteria for clinical diagnosis. Most of this is going to be how the patient presents and they have a discharge and what the labs show. So supportive criteria, sure, if they're febrile, they've got more discharge. ESR and CRP, I've never ordered one on a patient with PID. So diagnostic test interpretation. Pregnancy test, sure. Gonorrhea, chlamydia. White counts are rarely elevated on some of these patients. So you do a CBC, they're going to have normal white blood cell count if they've got PID by themselves, unless it's systemic or causing them to have fever. You're not going to see their white count bump. Fitzhugh-Curtis syndrome, you're going to have some pretty significant abdominal pain if you're going to have that. And your liver enzymes are not going to be bumped unless it's like late stage, I can't imagine. So, and if you're going to have pain like that, you're probably going to get more of a CT rather than just like doing a pelvic exam. So, imaging is transvaginal ultrasound to exclude a tubo-ovarian abscess. That's true. A big abscess you can see on CT, but a smaller one you can't. Plus, you can look at the blood flow in the ovary as well. And an IUD increases their chance of PID. And if you've got an infection, an STI with a IUD, a lot of times you have to take it out, because once it gets seated, you can't cure it at all. And so it'll just kind of keep getting re-inflamed from the same infection over and over again, so you have to pull those out. That's why they always test, so like, well, we'll put an IUD in a patient that has one partner, because the likelihood of them getting an STI is low. And yeah, laparoscopy can be done if you failed a bunch of it, but that's later. So you can read the ultrasound diagnosis there of how to diagnose that. Thickened MRI looks at tissue, so you're going to see thickened fluid, filled tubes, and tubo-ovarian abscess, but you're not going to get an MRI for a PID. So treatment, everyone wants to know about different treatments. These change a little bit, so by the time you guys are out of school, they may be changed again. They always say you basically want to treat, if you've got chlamydia, you want to treat for both, because chances are they both run together, chlamydia and gonorrhea. And so we treat a lot with azithromycin or Rocephin, and you can add on some metronidazole for longer term, but then this will be in your questions. But there'll be new, the CDC comes out with new regimens all the time, so like here's one for, there's a Rocephin and Doxy. So there's all these different regimens. It's a lot of stuff. Who can go home, who can't go home? And this is common sense stuff. Basically, if someone's throwing up to the point where they can't hold down meds, you can't send them home, right? If someone's been on other meds and they're not better and they need IV meds, then you can't send them home. If someone has pain that you can't get under control, you can't send them home. If you think they've got an abscess that needs to be drained that's not going to get better with oral antibiotics, you got to put them in. So, like, those are the types of things. So when you look at this, there's always going to be a bunch of factors. There are going to be certain things that you know that like when a patient comes in and has this positive test, you can't send them home. But the rarity is going to be clinical picture altogether. Because how young is the patient? How sick are they? What resources do they have? How likely are they coming back? I mean, all these parts that play an issue with whether patients come in or they go home are all going to be very different for every patient. So that's why you have to kind of understand, like, what types of things are destined to fail, what types of things are not, and then like how to go about to make sure that you don't send somebody home that's going to fail. Gosh, and a quick follow-up is good. You always want to have a way to have them follow up with their primary care. If they don't, the health department a lot of times will recheck for cure. You're going to treat somebody. A lot of times people can become asymptomatic, but their infection's not gone. So you always make sure that they will have a test of cure sometimes where they'll go, which is the health department have recheck. Also, what's really key on this too is your partner is going to reinfect. Their partner is going to reinfect them. So you got to treat both, because you'll be bouncing back and forth between the two and happens all the time. So they don't think about it, and then just they'll treat them and then they'll get it back again, or they'll switch back and forth. So PID, a lot of other things that could be. There's some pretty small specific things on this. Tubo-ovarian abscess is basically a secondary complication of this. It gets a blockage, and then bacteria grows and creates a walled-off area of an abscess. Sometimes these are connected where they do have a significant amount of discharge, sometimes they don't. Pain out of proportion is going to be one of your things that you're going to look at. So when people come in with terrible pain down here, if they've got discharge, you're going to think more infectious. You think, like TOA. If they don't have discharge, you're going to think like torsion or cyst or something along those lines. So that's why your questions play a big part. Like, how quickly does this come on? Tubo-ovarian abscess is not going to come on suddenly. It's going to come on gradually because it's an infection that's slowly been growing, whereas a torsion is going to be like sudden. So usually. So all the labs we talked about, your pelvic exam, imaging, and their treatment is typically, what they do a lot of it now, sometimes they'll go in typical of do like a laparoscopic surgery, but sometimes they'll do interventional radiology to actually drain these. So it depends on where you're at, they change things now. TOA, X-ray is important. Ultrasound is probably the standard to look for what's there. Some pictures. CT can be helpful. CT is a test that, I mean, it's basically a fancy X-ray, and so it doesn't see tissue all that well. It sees bone, and that's why if you've got a back issue, you can't really use CT very well. You use MRI because you see the tissue. But CT can see size of things. It sees abnormal sized anatomy. It can't tell you function though. So CAT scan is actually pretty good at seeing torsion because the torsion will get enlarged, and so it can see a big ovary. So 80% of the time is pretty good at picking that up. But it still can't tell you if there's blood flow or not, or what the real underlying issue is. It tells you there's a big ovary. And sometimes it gets misdiagnosed as a cyst. MRI. All right, so ovarian cyst, this is something that happens very common. Unfortunately, it gets dismissed because it can lead to other bad things. So you have follicular cysts, corpus luteal cysts. Every woman has cysts. They just do. And it's just some are symptomatic, some aren't, and also depending on the size. Typically less than a centimeter is no problem. Anything greater than 1 centimeter is technically abnormal, but a lot of women have no symptoms. You'll have a 3.5 centimeter cyst and they'll be like, oh, I don't have any pain. So you can't really rely on the size of it. But traditionally, the bigger the cyst, the more trouble it is. And it's every other month is going to be, it's going to alternate side to side. And so that's kind of like a little bit of a help to know, rather than if it's on one side, it would be something more pathologic to that area. Lots of different kinds of cysts, and you can read them up and too much to get through. Related to normal ovulation, higher levels of gonadotropins and cause ovarian cysts. And abdominal pain, sharp unilateral, previous episodes may occur with exercise. And these will tend to get better once they rupture, but then there's a secondary part where if they rupture, then it bleeds into the pelvis, and there's some people that feel very strongly about the fact that if you have a little bit of bleeding that gets down to the lower part of the pelvis, that blood in the pelvis will cause irritation and cause pain. So they can have the initial cyst, the stretching of the cyst is what hurts. It ruptures, they feel a little bit better, but then it bleeds after it ruptures, and all that fluid gets out and it gets down. And so then in that lower pelvic area, in the back part, they'll be irritated and that'll hurt. So that's kind of the progression of that. And polycystic ovarian syndrome, you're going to have irregular menses and a bunch of cysts, and you're going to have multiple cysts at one time sometimes. So it makes it really hard to determine what's going on. Okay. Unilateral tenderness, peritoneal signs. So what's the deal with the peritoneal signs? Rebound, tenderness. Let's see, 2 of hearts. Are they still awake? 2 of hearts. So how do you do an exam? Is there 2 of hearts? Oh, no, it's down there. All right. Everyone's like, whew. 8 of diamonds.
That's me.
Okay, so doing a physical exam, and so the peritoneal signs, rebound tenderness. How do you do the test, and what are you looking for? Like, what does it tell you, kind of a thing? I mean, people talk about it all the time, but like a lot of times people don't understand really what they're doing or why.
Aren't you just palpating and they're just kind of like guarding themselves, flinching, kind of?
They can, but the particular rebound test is, so basically what you do is you take your hand, you're gonna gently palpate all over and say, okay, you first ask where you hurt. Patient, 1 finger, and they'll go, 1 finger, I'm hurting like this here, 1 finger, okay, in this right here I'm hurting. It's like, okay. So it's hard to get them to follow directions, but when they do finally, you're like, okay, right here, okay, so then you check that place last, okay? here, over here, over here, okay, and you say, okay, when I push over here, does it make that other side hurt? That kind of gives you an idea of like what kind of sensitivity, how we're doing here. So then you go over the area and you go, okay, and you push down. You go, okay, right here's a hurt, yeah, okay. Now, and then I go down and I will hold pressure for a second, depending on how much they're jumping off the bed, but I'll hold pressure for a second, okay, all right, I'm gonna let go. I want you to tell me if it gets better or if it gets worse. And they go, what? And you go, real fast. And they go, ah! Or they just go, oh, it's better. You know, so that's what you get your rebound tenderness. So if you let go real fast and they get worse for that first moment, that's considered a positive peritoneal sign. It's a rebound tenderness. That tells you that the peritoneal area is all inflamed, and that could be something that's up against the abdominal wall. So you're not going to get that with a kidney stone. You're going to get that with like appendicitis, things like that. Does that make sense? So, you know, sometimes it's hard, and it's not super specific. That's also what we do with appendicitis, like a heel tap. You know, people laying flat, you know, tap their heel. Like, does this hurt? That's basically a poor man's peritoneal test. Poor man's CT for your CAT scan, for your appendix. All right, so peritoneal signs, ovarian cysts, because the ovarian cyst is going to irritate that lining on the back of the abdomen. Pelvic mass, oh Lord, you're rarely going to feel a ovarian cyst. If you do, they're going to be so unhappy with you because it's going to hurt like crazy. So I think the likelihood that's pretty low. Hemorrhagic shock, sure, if they rupture a bunch and they don't stop bleeding, you can, but you're going to see them be tachycardic and hypotensive and all that. So, of course, pregnancy test, erotic topic, H&H, lab tests, and yeah, I don't know what that. CBC, UA, okay, but mostly it's going to be ultrasound. And these are some very specific things I can't imagine you would need to know for right now. Yeah, it can lead to a lot of hemodynamic instability and shock, but it's pretty rare. All right, torsion. So one thing too, torsion has an increased risk with cysts. Oh,
I have a really quick question. Is it easy to see a ruptured cyst on ultrasound, like
No.
ultrasound? Okay, so you're looking
It's
for the
ruptured.
peritoneal, that's what I thought, but I was like, how can you?
And most of them aren't very big. I mean, like, they're average, and they can start, because if you can think about it, like, it gets bigger and bigger and bigger and bigger, and hurt, and it ruptures, and it moves itself. So then you can see it, but it's not as obvious as when it's like big and stretched out and hurting, so, yeah, no. I mean, it can be seen, it's just not typical, and it just depends on the patient too. So some women are just used to having cysts every month, so it's like, I'm used to this, and then some women will get a really big cyst out of usual for them, and they'll have much more difficulty with it. But then some of them will have big cysts, and like someone will come in, I had one lady with appendicitis one time, she had this huge ovarian cyst, she's like, no, it didn't hurt. It didn't hurt at all. I mean, it was like 5 or 6, you're like, gosh dang, it's huge. And her appendix was huge too, and that's where her pain was coming from, so it's weird. All right, so torsion is basically when the ovary spins on itself. Anything that can affect the anatomy. So the ovary is really, it's a poorly designed organ from a structural standpoint. It's attached basically 3 areas, you know, like it is different, but for the most part, you've got your ovary, I'm not an artist, but let's say you got your ovary like here, and it kind of comes down with the tube, right? And here's your uterus, right? So you basically have just like a few attachment points on this. So a couple different things. Anything that can affect its attachment. So cysts, when it gets a big cyst or something on here, it can cause it to kind of rotate, because you've got the vascular supply that'll come into it that'll get twisted. And that's another problem too, is that when you get a tubal, you lose one of your structural supports. So when a lady comes in, I've had a tubal, my concerns for torsion goes up. When they've had previous, cyst issues, or other problems like that, it's like more and more chance for that. So what happens is, if you've got your blood flow in here, and it's pretty straightforward, but you've got your venous and your arterial, right? So venous and arterial. Your low pressure side, this is going to twist on itself, put some pressure on it. The low pressure side will be closed off first. But that means the arterial flow will continue. We'll push past that initially. And then it'll fill up and get bigger and bigger and bigger and bigger to a point where that pressure will then block off arterial flow. But either way, you're not getting good flow because the venous is going to come down. So that's what we worry about with torsion. It's just, it can start gradually, and it can torse detours all the time. And so the classic board exam is going to be sudden onset, one side, worst pain of her life. And they may throw some other things in there like, oh, she's had, previous PID or other things like that, TOA, a tubal uterine abscess, so you can see how that could do it too. So anything that could make it abnormal. And like I said, 94% involve a mass in the ovary, cyst or neoplasm. And it is tough to diagnose, 58%. So they say on there, and I think part of it is why it's hard to diagnose is because there's so much is made up of the fact that it's sudden onset. The last one, not the last one, but one maybe 6 months ago, 8 months ago, I had this lady came in, she was probably, I think she was like 38, and she had a hysterectomy. And she came in for abdominal pain for 4 months. Abdominal pain, 4 months. One of those, okay, we'll rush into the day. And she's sitting across from me just like, yeah, this hurts. This is the worst pain I've ever had. I'm like, okay. I mean, no, so, the worst pain I've ever had. I have one nurse that goes, because you're always trying to get a pain scale, right? And they're like, okay, 0 being no pain, 10 being the worst pain of your life. And she'll always go, like a tiger is ripping your legs off. And you'll be like, and I hear it all the time. And she's like, okay, so knowing that, what's your pain level? And she'll go, it's a 10. She'll go, you mean right now a tiger is tearing your legs off? And they'll be like, yep. And you're like, okay. So, but depending on the patient will dictate what they tell you, but what they also look at. So this lady, I did a CAT scan. I did labs. Labs are normal. CAT scan showed a cyst, but nothing really abnormal otherwise. And I had even put the paperwork together to be discharged home, and I thought, I don't know, because she said, oh, it's been going on for months, it comes and goes, it's left side, and this and that and the other, and I was thinking, I don't know, and I mean, other exam, and no discharge, and all other stuff looked normal, and so I was like, well, I went there to discharge, I sat down and I said, so what I've been able to see on my side here is this, negative, negative, negative. But part of this is, you only know how you feel. I cannot feel what you feel. So, I mean, and you seem like a reasonable lady, and you've not come to the ER a bunch. Like, if something is wrong, you could tell me that something's wrong. So I'm just, and this was like after hours, and so I didn't have ultrasound in-house. So that was kind of like my, you have to be pretty, because I have some old crotchety ultrasound techs that hate to come in. But anyway, so it's like, am I going to need to hear a bunch of attitude to call this guy in for you? I mean, how sick are you? How much do you really hurt? And she's just like, yeah, this is probably one of the worst pains I've ever had. And I wanted to say, like tigers are tearing your legs off? But I didn't. I said, okay, all right, so fine. I took her discharge off the board, and I called ultrasound in. And he came in and was like, well, she's had a CT, that's normal, and blah, 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 and all this stuff. And I was like, all right, we'll just go do it. So he went did it, and he literally came running back in like 3 minutes later. He goes, oh, it's huge, it's torsion. I don't know how they didn't catch this on the CT scan, but there's no flow and this and that and the other. And anywho, so the other crazy part about it was, so I was like, okay, cool. So I pick up the phone, I call OB-GYN, I'm like, we got a lady, she needs to come over. And as soon as I hang up the phone, the night raise report comes from the radiologist. It says, normal flow. I was like, are you kidding me? So I called the guy, he's driving home. I said, they told me to go. That's wrong. He is wrong. He goes, I did this, that, and the other. I looked at this flow and that flow. I said, it's all, there's nothing there. The ovary is huge and blah, blah, blah. I'm like, okay. So then I called night raise and the radiologist said, is there any way this could be wrong? He goes, let me look at it. Well, yeah, I guess that ovary is pretty big. Yeah, well, maybe there's some collateral flow I was reading. I'm like, what? Anyway, so he changed it and the lady went off. And she called me about 3 or 4 days later and said basically they got her in the OR as it was rupturing. It was black. She sent me some pictures and it was just like black death in there. So if I had syndrome, she probably would have died. I mean, that's the crazy part. So this lady had it going on, and I don't know if she'd seen anybody for it before, but, I mean, obviously it's been going on for months. It was probably maybe a cyst or something else causing her some trouble, but it was probably torsion, detorsion. I mean, because it just somehow, I mean, once it torsions, it stays that way. It doesn't stay that way for very long. A couple days, and it basically necroses and rots, and then it just ruptures, and then it spills all that into the pelvis, and then you get people with septic and all sorts of other issues. So, but I mean, she was not your classic example. So like that's like a really good warning point for me is just trust the patient. They tell you, hey, something's wrong. Like this is not normal. And I mean, some people are like, oh, my back hurts so bad, I can't go to work. I need to work down on 500 Percocet. You're like, well, maybe not. But people that are like reasonable, don't just be like, well, it was a sudden onset. It wasn't this. And the CT scan looked okay. I mean, was this a defensible chart? Probably. But the problem is this woman had a terrible outcome. So it's like, it's bad for her, and then plus you're like, well, you could have done the ultrasound. I mean, I don't know, everything else it was such a needle in a haystack. But, so use that as like, if you ever think something's not right, something's probably not right. And that's the patient, that's another thing too. A lot of people never stop and go, hey, ask the patient if something's really wrong. Because people can be like, I don't know what's going on, but something ain't right here, it's like, they know, rather than, I'll probably be all right, I probably just need to not go to work tomorrow, I didn't know. Yeah, all right, so torsion is basically all that stuff. So it's a common thing, but you just, don't see it very often, so it's tough. I mean, they say that with certain bad illnesses, it's kind of like the tiger in the woods, you don't see it, but it sees you, so just be careful. So the blood supply gets shut off, and the venous drainage stops, arterial supply continues, congestion, swelling. So that's why the CT can see it, because if the ovary swells up, CT can see size, right? But it can't see function, so it can misdiagnose it as a cyst. Who is at risk for this? Reproductive age women. But even afterwards they can, because the reason why is because they have more cysts. They have every month they're going to have another cyst to deal with that can increase their chances with it. And then older women are going to have more of the like cancers type growths on there, so that's going to be there. But typically they just take it out. Pelvic pain, yes, sudden sharp colicky. A lot of times it is. And what's weird is the torsions that I've seen, like, are not as dramatic as some of the ones that come in, and these women are like, oh God, you're thinking, this lady has torsion, here it is, this is classic, this is what she's going to have, she's not going to have a kidney stone, blah, 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 and they don't have anything, or they have a little cyst or something, you're convinced they have it. So the patient's presentation can lead you astray, but just remember, keep a wide differential. It can refer pain down. It gets misdiagnosed a lot of times with appendicitis or a kidney stone. Those are the two kind of similar things. So if you've got a patient with any of those sorts of symptoms, always have torsion in the back of your mind because you don't want to miss it. And their vital signs may be very variable. Pain. Ultrasound is the diagnostic test. And then you just treat them otherwise. You give them pain meds, you give them fluids. If they're bleeding a bunch, you give them some blood. There's nothing really fancy about that. Once you find the torsion, it just needs to be fixed. If it gets fixed early, they can usually tack it down. They can detort it, tack it down, keep it from moving. If it's a young woman who wants to continue to try to have kiddos, then you try to do what you can on saving it. Otherwise, most of the time, they just take it out. It's been there too long. Admission criteria, basically, if they have to go to surgery, usually they'll wash them clothes, depends on if they rupture or not. You don't send these people home, so it doesn't matter. Yeah, look at that, and that ugly down there, golly. I mean, look how many times it spins. It's not, I mean, that's weird. All right, so pearls, frequently missed, so high suspicion. Yeah, and do not get influenced by ordering tests on what you think are going to, because the ultrasound techs, a lot of places I've worked at, they're like, come in at 8 o'clock at night or whatever, like, let me guess, torsion, and they all mad, and they're all back there, and they go, guess what, no torsion, you're like, okay, good deal, But that one time, that old guy, he does not give me as much crap as he used to, because when I found that one lady, I mean, he was just like, oh my God, there's nothing wrong with this lady, she's got to use, he never gets excited, so. Just make sure that you don't let, if you have your gut instinct to order a test, order the test, order a test. Don't let patients or family or other people dissuade you from doing it, because you're not going to be good. But if you're lucky, that's the best part. Because if you have a high suspicion of something, then just do it. Because there's no excuse on the flip side of it. People all the time go, I don't want to do an ultrasound. How's that going to look on the stand? You go, well, so she had the abdominal pain. How does the torsion typically present? Oh, pain down there and all that stuff. So how do you diagnose it with an ultrasound? Why did you call an ultrasound? Because he was at home eating dinner and I didn't want to disturb him. Was he paid to be on call? Well, yeah. Is he paid to come to the test? Well, yeah. So why didn't you call him? Well, because he's really grumpy and I hate to call him because he's always, yeah. So don't let that influence you. I know it's hard and depending on where you work, but anyway. All right, here's a little kind of flow chart. Vaginal bleeding. Most of the time it's benign. A lot of times it's, women can have irregular menstrual cycles. Sometimes it can be other, ectopic and stuff like that. So it's a wide variety. So there's painful bleeding, there's painless bleeding. And so that's kind of like how I first put the thing into it. But you're going to have a little bit of pain with regular menstrual cycles. So some women have very painful menstrual cycles. And so it's kind of hard to tell all the time. You're like, well, is this typical of your menstrual cycles? Or is this something that's going to be out of proportion to it? So you always got to think about ectopic. And then if they're pregnant, any other kind of threatened incompleteness, all those sorts of things, molar pregnancies, trauma, and then later in pregnancy you have all these other problems, so I think they're going to go through that. Non-pregnant, dysfunctional uterine bleeding, so fibroids and polyps and tumors and all this stuff is kind of not going to be sudden. So these are things that people are going to be having going on for a while, so you'll have time to work this up and have ultrasounds and things like that. And they can be, also some women have also worsening bleeding if they have like a bleeding disorder, like von Willebrand's or other kind of thrombocytopenia, purpura, stuff like that. Foreign bodies, that happens quite a bit, believe it or not. People lose track of things. I could give my foreign body lecture, but that's a whole other deal, so get all signed waivers and anyway. All right, so vaginal bleeding, and depending on how much bleeding is going to determine what you see. And so one of the things is how much bleeding are you having? Getting an idea of how much bleeding is the most important part, because everyone goes, I was going to stop bleeding. Oh my gosh, you're like, okay, well how much bleeding are you having? And they're like, oh, I've had twice as much bleeding as I normally do, and it's just like, I've had a thimbleful, this afternoon, and you're like, okay. So if you have a lot of bleeding, you got a lot of bleeding, and you'll know that typically the patient will be tachycardic, and you'll have where it will go more than, a pad every hour or 2 hours is significant bleeding, and also depends on the amount of bleeding. Some people change out their pads like all the time, one little tiny drop of blood, they want a new one, versus some will wait until it's no longer working to change it out. So getting a quantification of that, and the nurses a lot of times will be good with that too, as they kind of get them to a gown and stuff, it's like, oh my gosh, there's bleeding everywhere, versus there's nothing wrong with this girl, she's fine, send her home, whatever. I mean, some people come in, they want a menstrual, they want a pregnancy test, and because they think they're pregnant, but really they're just maybe having a menstrual cycle. So a lot of different reasons for vaginal bleeding, and that's, and you see this long list of all these different things. It's, your questions are going to knock that down really very quickly, because your pregnancy test is going to be your first thing, pregnant, not pregnant. So not pregnant, okay, we go down this other pathway, and then it's like sick, not sick. Are they pain versus not pain, tachycardic, not, and nuclear vitals, and so there's kind of like this differential where you can go down to kind of break it down further. So more and more information is important. So your physical exam, it's, your history is the most important thing, I think, because what they can tell you. Your physical exam can tell you a little bit, but you're pretty much going to have a short differential by the time you go to check their abdomen after you've asked them all those kinds of questions. So, and then the pelvic exam, where is the bleeding coming from? Sometimes they can have trauma and they don't want to tell you about it. And I've had some lacerations inside the vaginal canal from doing things they shouldn't be doing, with things that they shouldn't be using. And people will never cease to amaze you, I guess is what I can say on that deal. So just have an open mind and say, now, how did this happen again exactly? What's the real story? If something doesn't make sense, keep pushing questions, because there will undoubtedly be some other reason why something happens, so. And people look on the internet and think they can do things that people do. Bad idea, bad idea. Okay. So, pregnancy tests. Let's talk about pregnancy tests. Have you guys talked about pregnancy tests before? So, all right, 6 of diamonds. Who's 6 of diamonds? All right, what kind of pregnancy tests typically people get?
Over the counter,
Okay, so what kind is that?
HCG quantitative.
Yeah, so all of them are looking at HCG. So there's urine, right, over the counter, and then what's the other one we can do? Serum, okay. Which one's better? Serum quant. Okay, that is the most accurate. But realistically, we usually, it depends on where they're at, is going to determine what you get. So, the initial test is the urine pregnancy. It's a very good test, but there's some caveats as to it can be a false negative. All right, so why would a urine test be negative even though the patient's pregnant? Queen of clubs. Did you just tell her the answer?
Low HCG.
But why? That's the key. Why? Why would your urine test, you have a woman go in and give a urine sample and comes back out, goes to the lab, and it's negative. Yet she is positive. She is still pregnant. What are the 2 caveats to that? So it is the level HCG. So why would the HCG level be low? Okay. So one is it's too low. So one is it's too early. Okay? Because it takes a while for, think about it, process, not memorization. So if you have a pregnancy, it's in the uterus, and it's producing HCG. Well, it has to get to a certain level before the kidneys don't allow it, or kidneys can't handle it anymore, and it spills over into the urine, right? So that first few days, up to like a week or so, you could have it in the blood, but not in the urine. So too early pregnancy, that's why I say, 5 to 7 days, know it earlier, whatever, this test is more sensitive. I don't know. They're all pretty much the same. We use the same technology as a dollar store, but people want to come and have a $1,000 test, so whatever. So that's the first thing. And then there's one other caveat. So 8 of hearts. All right. So if it's too early is 1, because HCG is too low, what would be other caveat why the urine test would be?
I really don't know, but could the urine be dilute?
That's right. Yeah, that's exactly it. So if a woman's drinking too much water, that's why they like to do a morning pregnancy test, and because the idea is it'll be more concentrated like that. But if they're drinking a bunch of water throughout the day, they can dilute it. So the specific gravity, different tests are different, but most of them are 0.015 is specific gravity. If it's like less than that, usually you've got worries that it's too dilute. So we got to be kind of careful with that. So then we run over to the serum. If you're going to get blood on a patient, don't waste your time with urine. Just get the blood. And so you get the qualitative and there's the quantitative. Qualitative is a yes or no, and if it's yes, then you want to know the quant. So you want to know what the level is. So because then it'll tell you like kind of how far along they are and stuff like that. So and so the other thing is if you've got a positive pregnancy test and you get a quant level and you say it's over 1,000 or whatever. Typically 1,000 is the first cutoff, is when you start seeing things. So you get like a gestational sac, and that way it helps the ultrasound tech know what to look for. If you have a quant that's like 97,000, you're like, okay, well this patient is definitely pregnant. So it kind of helps you to understand like what they're looking for. So that's why that quant level is so important, and then plus the quant level we'll be able to use to retest. So later pregnancy, these are the things you need to order. Type in RH, because if you're bleeding, you could be exposing the baby. Do you guys know which RH it is? Okay, yeah, so if mom is negative and baby could be positive, so that's why, yeah. All right, and then feel the heart tones, ultrasound. Yeah, if you have a miscarriage and you may have products of conception afterwards, you get an basically, if you've got a pregnant woman, you get an ultrasound, so. All right. And transabdominal, that's usually if it's pretty high. You see an HCG greater than 6,500, that means it's got to be big enough to be able to see. If it's not, you do transvaginal, that's earlier. So fluids, oxygen if you need it, they're unstable. Yeah, just resuscitation stuff. Also, so if you've got an ectopic pregnancy, then if it's caught early, you consult OB-GYN, they'll usually use methotrexate, that'll be your board question typically. They'll usually ask you to give it, although it's like a chemo drug, it's listed as also, so you sometimes can't even give it, they have to have like, certain facilities won't let you give it without having people co-sign for you, so it's kind of a weird deal. So ultrasound indeterminate for engineering pregnancy or ectopic greater than the institutional discriminatory zone. All right, so let's say you have a lady comes in and she's hurting and she has some spotting and she doesn't know when her last menstrual cycle was and her pregnancy test is positive, so you do a quant level and her quant is, 2,000. Okay, so she's over that threshold where you should maybe see something and you send her for an ultrasound. And the ultrasound tech comes back and says, I don't see anything, there's nothing there. So jack of clubs. There's jack of clubs. All right, so what are your thought process on that? Because you've got basically, she's had the positive HCG. She has a high enough level you should see something, but the ultrasound shows nothing. So what are your possibilities at this point?
You could still get ectopic, just not in tubes or something, so
Correct.
maybe.
Anywhere it's not in the uterus is considered ectopic, right? So it could be in the tube, could be in the pelvis, all over less common, but yeah. So it could be ectopic because you can't see it. It's harder to see it in the tube, correct. What other thought process?
It could be an HCG producing cancer.
Correct, that's also a possibility. What's the most common thing probably though?
Would it be a miscarriage?
Yeah, it'd probably be a miscarriage because if there's nothing in there and she should have something in there with 2,000 most of the time, she probably just had a miscarriage. And some women are pregnant and they don't even know it the first month when they have a miscarriage and they think it's a menstrual cycle or abnormal cycle and it's gone. So it's tough sometimes. They won't follow their menstrual cycle very closely and they'll actually have a little irregularity and they'll have been pregnant and they didn't know it. So, all right, so for these patients, what we need to do is have them come back in 48 hours to have the HCG repeated. Why do we do that? 5 parts.
To confirm, the HCG said like 4 times or 2 times the increase.
But why does it do that? You guys have been told that? Okay, so basically, here's the idea. What is the uterus? Why is the uterus so good, right? Why do we have this organ that does such a great job at birthing or growing babies? Blood flow, right? It's got thick blood flow. It has a thick wall. So wherever this baby gets implanted, boom, there's all this blood flow to it, and you can grow it really well, right? That's pretty impressive what we can grow. I say we, but humans. So it needs a lot of blood flow to grow this thing, right? And so we know from studies that say that the HCG will double because it's growing so dang fast. Why is it double? Because our cells double, right, in the beginning, right? So here's the issue. If you're in the tube, there's not very much blood flow there, right? So you don't get as good blood flow. That's why one of the caveats is the HCG will double every 48 hours. Because if it's in the uterus, it'll double. If it's not, it won't, but it'll keep going up a little bit. It will go up, but not as much as it would be if it was in here. So that's why we have people come back, recheck the HCG. If the HCG is going down, then we're thinking miscarriage. Baby's not there anymore, so it went down. If the level is a little bit up, we're worried about it growing someplace else. But if it doubles, we think, okay, it's probably in the uterus, and it just wasn't seen earlier, and we'll look again. So that's kind of why that process is the way. Now, there are some caveats to that. You can have a heterotopic pregnancy, which is when you've got one inside and one outside. Those are rare. Or caveat is you have twins, right? Twins will double up your measurements too, but usually that just makes it go much higher. So, but the heterotopic is like, so you figure ectopic pregnancies are 2 to 3% of pregnancies, and of those, 1% is a heterotopic. So I mean, think about where that is. So you can get fooled. So if you have a lot of pain, and you do your ultrasound, you've got this picture of a baby and you're growing early on, then, but you have significant pain, you've got to think ectopic, because it could be growing the second one, even though the one inside looks okay. That make sense? All right. So when do ectopics typically present? Let's see, Jack of Hearts.
Oh,
When do ectopics typically present?
couple months in, I don't know.
6 to 8 weeks. And why would that be? Any thoughts? Because at 6 to 8 weeks is
When
when
it's
it
just
starts
big
to
enough.
outgrow the size of the tube. 6 to 8 weeks it starts putting pressure on that tube, and that's when they present because it hurts, and they may get some bleeding and stuff like that. So it's a mechanical thing. Does that make sense? Okay, these are just simple diagnoses. You guys need to know this stuff. You know, complete, incompleteness, septic, molar, so. All right, previa, placental abruption. So previa is, and I think of this as a preview, right? So, if you've got your uterus, kind of comes in here like this, in the cervix. Right? So, when the baby implants, comes down here, where it implants, covers the cervix opening, then that's going to be a previa, it's going to be blockage there. Now, most of the time, early on, we watch these, right? Because the baby will start here, then the uterus will get bigger and longer, and then this will migrate up as the uterus will grow up. It'll move up here, and then if it gets over to here, you're okay, as long as it doesn't come over the front. So, the previa is one where you can't have a normal delivery because it'll break through. So that's just something you have to watch with OB and ultrasound. But that's kind of, sometimes bleeding will come because it'll bleed easier that way if it's covering that way, because it's not implanting very well. Or it'll kind of turn the corner over the os and stuff. So your os is right there. An abruption is when basically the placenta just comes apart. You get a separation here in the blood, and that's dangerous for 2 reasons. One, you can get a whole bunch of bleeding, but 2, more importantly, baby loses oxygen, because if you got a big blood or a blood clot or hematoma between the placenta and the uterus, there's no oxygen being transferred. All right. Oh Lord, also go one step. All right, so. Vaginal bleeding, treatment procedure, structural abnormalities. So any kind of lesions can bleed, and you will get an ultrasound looking for pelvic masses, fibroids, uterine tumors, and those things can bleed and they hurt too. So estrogen will help with stopping the bleeding, and progesterone will also help too. The anatomy, the analogy they give is that the estrogen is kind of like bricks on the wall that holds back the bleeding, and then the progesterone is like the mortar that holds the bricks together, kind of a thing. So both of them work together, but look a little bit different. So you have too much estrogen over time, it doesn't hold as well as progesterone. But different hormone combinations will be different, but none of this is going to be on your test. I don't think. I can't imagine. Okay, admission, so anybody who's sick can't get better, so ectopic pregnancy, can't give methotrexate.